And the second session now is very interesting. It is on some of the pharmacotherapeutic advances of the last year. And we have a distinguished panel of speakers, my own teacher, Professor Kerkar, Dr. Bhavesh Vajivta, Dr. Karnik. So I call upon the chairpersons, Dr. Darshan Jhala, Dr. Uday Khanolkar, and Dr. Vaibhav Dedia sir, to please chair the session and begin proceedings. Thank you.
Yeah. So may I invite our close friend Dr. Praful Kerkar, speaking on pulmonary hypertension, a therapeutic primer.
Well, good afternoon. So at the outset, thank you to the organizers, especially my teachers, Dr. Pelajani, Dr. Satyavan Sharma, and Milind Fadke. So the global prevalence of pulmonary hypertension is low. It's just about 1%. But one must remember that 80% of the population with PH is from our developing countries. So we need to show interest in pulmonary hypertension. Moreover, this prevalence increases to about 10% in older individuals, as also regrettably, the time from symptom onset to the PH diagnosis is such a long period, 2 years. So we need to have early diagnosis. So how do you define PH? Moving away from the good old arbitrary and somewhat, empirical definition, today based on large patient cohort studies which have shown that a mean pulmonary artery pressure between 19 to 24 millimeters of mercury also is significantly associated with a continuous increase in mortality. So the modern definition, the latest definition is mean pulmonary artery pressure more than 20 millimeters and a pulmonary vascular resistance of more than 2 Wood units. Add to that, there are these confusing terms, not really. Pre-capillary pulmonary hypertension or pure arterial pulmonary hypertension means the left heart is okay. The pulmonary artery wedge is less than or equal to 15 millimeters. There is isolated post-capillary pulmonary hypertension, which is typically due to left heart disease, and the PA wedge pressures are more than 15 millimeters mercury. However, the PVR is normal here, though the mean pulmonary artery pressure is elevated. And then we have the combined post-capillary pulmonary hypertension, wherein both pulmonary artery wedge as well as PVR are elevated. So also the classifications have evolved. Good old days, there were just 3 groups. We had those things called primary pulmonary hypertension. The latest classification of 2024 says that group 1 is referred to as pulmonary arterial hypertension, the pure pulmonary hypertension, that is to say. And based on etiology, we have group 2 where there is left heart disease, group 3 with lung disease and or hypoxia, pulmonary obstructions in group 4, which is a very important entity, CTEPH or chronic thromboembolic pulmonary hypertension is a part of this group, and then the unclear and the multifactorial mechanisms. So before we set out to giving therapies to these patients, the diagnosis of PH and any potential associated etiology should be in place. And why so? Because PH specific therapy has not been found to be beneficial in most other forms of PH and may in fact be harmful. So you got to have your diagnosis in place, and the guidelines recommend acute vasoreactive testing. Hardly ever done. Even we cardiologists, busy labs are not inclined to do this. And if at all you want to select patients, the one which are responsive or idiopathic pulmonary, all the group 1s I'm talking about, idiopathic pulmonary arterial hypertension, the hereditary pulmonary hypertensions, or drug-induced pulmonary arterial hypertension. And why we do that? There is a small 5 to 10% of patients, a small subset of patients that you can identify which are going to respond to calcium channel blockers. And again, this response may not last. 1 year down the line, you might have to still bring them back onto the PH specific drugs. And all important underlined is the baseline risk assessment before initiating PH therapy. And that is because the key goal of PH therapy is to achieve and maintain. Where do I see my timer out here? Behind. I need to see it here. Now that isn't working. So, chairperson, excuse me if I exceed the time. Yeah, so coming back to key goal of pulmonary arterial hypertension is to achieve and maintain a low risk. So risk stratification is important. That's the goal we are talking about. And this risk assessment, not only at the baseline, you need to periodically keep on doing it. First follow up 3 months later, but periodically keep on doing it to see which risk category does your patient belong, so that you are good to up titrate medicines. And there are a whole lot of variables out there, this long list, which is based on clinical, non-invasive, invasive parameters. But a very easy to use online calculator available just on 6 non-invasive parameters is this Reveal Light 2 score. And for instance, this is our patient here. The last 5, the first one is not with us. We've used 6 parameters and come to a risk score of 6, which means it falls into the intermediate risk, not the high risk. But you do NT-Pro BNPs, you find the NT-Pro BNP was somewhere 1300s. So more than 1100, another 2 points added, he becomes a high risk patient. At once, whether your patient is high risk or low risk. Why? Because if it's high risk, upfront combination therapy has to include, this is all of course theory, a parenteral PPA. Parenteral PPA meaning prostacyclin pathway agent. But these are all parenteral, not available to us lesser mortals Indians. But the closest we have as an oral PPA is Selexipag. We'll talk about it more. So that is how it is, the high risk patient. Even if you are not high risk, it's not about starting one drug, then adding another one. Just like our other hypertension, the essential hypertension, here there is data and evidence for upfront dual pH specific therapy. So coming to the therapies themselves, we have done a remarkable progress. We didn't even know about sildenafil when we started doing trials for PAH drugs. And from there we moved to 3 targeted pathways, the ERAs or the endothelin pathway, endothelin receptor antagonist, that is the nitric oxide pathway, which includes both the PDE5 inhibitors and the newly introduced, we know about vericiguat. Likewise, there is a riociguat, a soluble guanylate cyclase stimulator, and the prostacyclin pathway. As I mentioned, Selexipag is the only oral one available. And there are nice 11 molecules available to you. We know about ERAs, the best amongst them in terms of hepatotoxicity at least is ambrisentan. Then there is a 4th targeted pathway which should become available to us next year, sotatercept. Sotatercept is, we all know, so this one about pH is characterized by what? Remodeling, a proliferative remodeling of the small arterioles and progressive luminal narrowing. And this drug acts on the BMP actin signaling pathway, sotatercept. So we have 12 molecules today. And why are we talking about PAH specific therapy? Is there evidence not only functional improvement, quality of life, 6-minute walk distance, and the PVR reductions, importantly, early diagnosis and an aggressive approach, although not in individual trials, have led to a improved survival from 2.8 years at the time of diagnosis to going on to 9 years, which is huge. So we should take this thing seriously. If you were to look at real evidence as such, a long ago done meta-analysis of various pH specific drugs versus no drugs at all, and you get a 43% mortality reduction. So that's as far as these drugs were concerned. I also talked about upfront dual combination therapy. An Ambition trial is the one that changed this landscape from monotherapy to upfront dual therapy. Herein it was ambrisentan plus tadalafil, and you can clearly see it is much better than either of the pooled monotherapy group, and showed a reduction in the clinical failure. And this recommendation of upfront dual pharmacotherapy, which also is news to me, even I have started single and then added on, is been in guidelines since 2015. So having said that, there is another combo preparation, macitentan with tadalafil called Opsinvi, which is not available with us, but macitentan along with tadalafil. Again, you do not have to up-titrate macitentan, unlike ambrisentan. And by the way, ambrisentan and tadalafil combo comes as 5 plus 20 of tadalafil, and you, to get the maximum response, you got to actually double the dose there. And out here, you can see how this combo preparation on this, the RV has remodeled, become smaller, and the bowing of the septum has become more globular LV here. So that's how it is. So not one but two trial. So class 1 recommendation for upfront combination therapy either with ambrisentan and tadalafil or macitentan and tadalafil. Then you might ask, PH is a progressive disease. Why can't we start upfront, especially for the high risk ones, all three together, all the three pathways together? Such a trial, in fact, is class 3 recommendation as an upfront. The Triton trial failed to meet its primary endpoint. It was no difference there and therefore not advocated. But if you see an exploratory analysis, you see that there was a 41% reduction in the progression of disease, emphasizing the point that you must uptitrate in the future, if not at the beginning. So sotatercept, I spoke about it, the anti-proliferative pathways, that is the BMPR, and the pro-proliferative pathways, the activin. It restores a balance between these two. And that's how that's the mechanism of action. And the stellar trial, just NEGM 2024, came out to be significantly positive for the primary endpoint, basis which it has got an FDA approval, and next year this drug would become available to us. For the future, it is being tried also in children with pulmonary arterial hypertension, adults with pulmonary hypertension with a high mortality risk, class 3 and 4, as also newly diagnosed PAH, it is being tried. So as an editorial to this, this is what the authors had to write, and it caught my eyes, that the era of remarkable progress in the care of patients with this devastating disease has not come to an end. Truly so, because if we see the list of trials that are going to happen and the emerging therapies, and if you look on the, sorry about the small print, but if you look at the left-hand side, we are so good at SGLT2 inhibitors, we have SGLT2 inhibitors, we have, oh God, it's all over, is it? SGLT2 inhibitors, we have antihistaminics, we have imatinib, the tyrosine kinase inhibitors, both oral and inhaled, and also metformin that is being tried for PH. So having classified them as not high risk or high risk, on basis of the risk stratification, you go on up titrating medications. And there are inhaled medications also, which are also not available to us, but inhaled medications for group 1 PH have the rationale that you can directly deliver the therapy. Then you ask one liner each on each of these, that for all the rest of the groups, you address the underlying cause first. For instance, left heart disease, you got to treat the cardiomyopathy or valvular heart disease first. But it is a fashion to give sildenafil for these patients. But there are conflicting evidence and it is not recommended really. If at all, for the future, for HFpEF, there is a levosumindan that is available. That is come out positive in a phase 2 trial, and sotatercept, as I mentioned, is being tried. For group 3 PH, again, only PH-ILD, and that too inhaled treprostinil is approved for this, that is the oral PPA. That as also surprisingly a PDE5 inhibitor for ILD patients with severe PH gets a class 2B indication, not otherwise. And CTEF I mentioned, something that should not be missed. We have Dr. Yadava here as a surgeon. Surgeons are very good at tackling CTEF. So there is nothing like an area of the pulmonary tree that they can't tackle. And on a CTPA basis, pulmonary thromboembolectomy is a therapy of choice. If not, we can even do balloon pulmonary angioplasties or then use PAH specific therapies. Riociguat has been used for treatment of CTEF and also gets an approval. And finally, to conclude, early diagnosis and treatment is important, that the prevalence is there, especially in the elderly left heart disease. There is more and more of it. Today is an exciting era. There is lots on the anvil, but you must embrace these PAH specific drugs and be there continually risk stratifying and up titrating the drugs. Thank you. And sorry for exceeding the time.